Hello, everyone. My name's Alex Pace. I'm a master's student at Brock University. Today, I'm going to be sharing with you my research titled Caring for Young Children, Out of Pocket and Opportunity Costs of Pediatric Emergencies in 5 Niagara Hospitals. Some background, Pediatric Telemedicine Connecting Hospitals, also known as PEDS-TEC, is a pediatric teleresuscitation intervention which was developed in partnership with Niagara Health, Brock University, and McMaster's Children's Hospital in December 2018. This network aims to enhance pediatric outcomes for infants and children who present to Niagara Health Hospital's emergency departments through a virtual link which connects pediatric specialists at McMaster to the peripheral NH sites. The objective of our study is to explore the out-of-pocket costs and time/productivity losses for parents whose child presented in the emergency department and underwent resuscitation using the PEDS-TEC program. And note these qualitative findings are embedded in a larger economic evaluation of the PEDS-TEC program. So using a purposive sampling method, we conducted 5 in-depth virtual interviews, and these were conducted with parents of children seen and assessed in the Niagara Health EDs from December 2018 to November 2021. These interviews were audio recorded and then analyzed using deductive content analysis and inductive thematic analysis. The purpose of these interviews was to understand the costs associated with the program from a patient perspective, with the focus being on the out-of-pocket expenses such as costs associated with transport, accommodation, and meals. We also wanted to look into productivity losses which could result from parents missing work. So below you'll see a flow chart of the interview process. So parents of children treated with PEDS-TEC were contacted for enrollment. Parents then consented to the interview process. The virtual interview was conducted inquiring about out-of-pocket expenses, and then interviews were analyzed deductively for out-of-pocket expenses and inductively for themes relating to the use of PEDS-TEC. And you'll see that this is a full circle process, as it's an iterative process where we make changes and tweaks throughout. Moving on to the results, we have our out-of-pocket expense results. The largest category in terms of both overall cost and response rate was travel/parking costs, which the average cost being $435. All children of those interviewed were transported to McMaster's Children's Hospital for tertiary care. Therefore, all parents had to make the commute, with the average number of trips being 5. Next most common response to expenses incurred was the cost for food and meals at $80 average, with a response rate of 3 out of 5. Now you will see in our table, you will see each participant's ID and their answers to each costing category. And along the bottom, you will see a total average cost per category. Moving on to the thematic results. So themes related to the feelings and perceptions of the PEDS-TEC intervention were captured through quotes directly from interview participants. So some of these quotes, it seemed pretty fluid. They all knew what they were doing, said the first participant. Next, I felt very confident in what was happening, especially when they introduced me what they wanted to do with the link with McMaster. I felt we were doing the right thing, said the second participant. The thing that I found went really well was the fact that pediatricians were able to communicate with each other through the technology, said the third. If it helps my kid in the moment, I'm fine with it. I had no arguments against it, said the fourth. So now on to our discussion and conclusion. The results of the qualitative interviews provided insight on the out-of-pocket costs associated with the interventions like PEDS-TEC. The major out-of-pocket costs resulting from treatment using PEDS-TEC were largely related to travel from the Niagara region to the tertiary hospital. This can be explained by the proximity of the hospital to the Niagara region, where our participants reside, which was found to be 73 kilometers on average from their home to the hospital. So for the PEDS-TEC program, those who are treated are often under extreme circumstances and require transfer. This was seen by the high transfer rate among our cases, which was 77%. The high transfer rate, along with the proximity of the tertiary hospital, resulted in parents making the commute multiple times, 5 times on average, which explains our large fee associated with travel. Interviews also provided clear evidence on the opinions regarding the use of PEDS-TEC on their children. Parents were impressed with the efficiency of the intervention and the communication ability that resulted from the video calls with McMaster. That's it. Thanks for listening.
Hi everyone, and thank you for coming to Niagara Health Research Day today. My name is Dr. Brienne Hines. My doctoral research study looked at a retrospective and forecasting analysis of increased long-term care demand in the Niagara region. So let's get right into it. So the background obviously is that there's been an increase in the aging population in Canada as well as an increase in chronic conditions. Patients are now waiting in hospital for long-term care secondary to a lack of long-term care beds, and acute care is on average 20 times more expensive per day than a long-term care bed in terms of funding from the government. So the problem statement, there were two. From a social perspective, a lack of hospital flow negatively impacts the patients who the Canadian healthcare system can effectively and efficiently treat. The specific healthcare administration problem that was found was that it's the responsibility of the government to ensure that funds are being allocated efficiently. The dispersing of funding is at the discretion of the local health integration network, who must make financial decisions based on research like this. So the variable, it was a length of stay for patients awaiting a most appropriate discharge destination of long-term care in both acute care and complex care between the years of 2017 to 2019. This information was inputted into a forecasting SPSS model to assess the number of long-term care beds that would be required not only now, but also moving forward. So in terms of the research questions, there were three. The first is there a periodic or seasonal effect in the data for patients waiting a most appropriate discharge destination of long-term care between 2017 and 2019? Research question number two, within the forecasting model, will a continued increase in the need of long-term care beds be shown in the Niagara region? And then research question number three, do medical complexities identified by case managers increase a patient's length of stay for transitional care and long-term care beds? So section two, the method and design, it was a quantitative research study. This allowed myself to forecast demand and numbers of long-term care beds in the future. It was a multivariate analysis using a forecasting model using retrospective data sets. This design allowed me to, again, see how many long-term care beds might be required in the future. So the participants and sample size, so we looked at all patients designated ALC between 2017 and 2019 with the most appropriate discharge destination of long-term care, as well as the identified complexities of those patients. Forecasting models require a minimum of 50 data points, which this study had 156 points due to the 3-year retrospective nature of the study. So in terms of the interpretation of the findings, research question number one, we were able to reject the null hypothesis and accept the alternative hypothesis that there was indeed a seasonal effect to the data. The dummy variable that was created was the winter variable, therefore finding fall to be the highest time that patients wait for the number of patients that wait in hospital for long-term care to be fall. These are just some of the ANOVAs and collinearity statistics that were run for that specific research question. Research question number two, within the forecasting model, will a continued increase in the need for long-term care beds be shown in the Niagara region? We are able to say yes, that there would most certainly be a continued increase in demand for long-term care in our region. The forecasting model showed by 2027 that on average 509 patients would be waiting per week for long-term care. The current funded capacity for Niagara Health is 600 beds, so that leaves less than 100 beds for actual acute patients. So this is just a show of the weekly trend that was seen in the data, as well as the projected wait for patients. The third research question was, do medical complexities have a statistically significant relationship with patients waiting a most appropriate discharge destination of long-term care? We were able to say yes, that this was indeed in fact the case and reject the null hypothesis. So both the total number of complexities showed a statistically significant relationship with length of stay, as well as 12 individual medical complexities shared statistically significant relationship with length of stay. These are the different medical complexity codes, and then the significant values. So the study was able to expand on previous published research, as well as expand on the extent of the financial imbalance occurring in currently and potentially in the future. And it also expands the knowledge of how many long-term care beds are needed in the Niagara region. With this study, we hope to advocate for an increase in the number of long-term care beds. This will also help with the quality of life for these patients. Types of beds that need to be most expanded upon were dialysis beds, an increase in the medical complexity of patients, and 4-bed ward accommodations. This would allow for an increase in hospital flow and a decrease in the financial burden of ALC patients. So the people that will benefit from the study are the elderly patients in the Niagara region, families of the patients and residents in long-term care, as well as the Niagara region residents. So in summary, this was a retrospective quantitative multivariate analysis with seasonal and periodic changes seen between 2017 and 2019. It also showed the inefficiencies in current funding structures of the healthcare in Ontario, specifically the Niagara region, will potentially have crippling effects in the future, and shows the type of long-term care beds that are most required for the expansion. Thank you so much for your time. Take care.
Hello everyone, I'm John V, a third-year medical student. I'm really excited today to share with you all our project titled Assessing the Ordering Patterns of Urine Cultures Without Proper Clinical Indication. Urine cultures are easily collected and subsequently frequently ordered in many different clinical settings. Choosing Wisely Canada and the Infectious Diseases Society of America guidelines give specific clinical indications for ordering urine cultures. These guidelines aim to decrease the treatment of asymptomatic bacteriuria. Consequences of treating asymptomatic bacteriuria include increased drug-resistant organisms, patient exposures to antibiotics, and increased hospital costs. So, through this project, our aim is to understand what percentage of urine cultures are being ordered without proper indications, and what percentages of positive urine cultures have proper versus improper indications for treatment. We conducted a retrospective chart review of all urine cultures ordered at the Greater Niagara General Site of Niagara Health from January 1st, 2019 to February 28th, 2019. Our patient population included all adult patients, that is 18 years and above, admitted and receiving urine cultures during their admission. Collected data from charts included documented reason for urine culture results, antibiotics at the time of ordering urine cultures and its receipt, and patients' comorbidities, along with the different types of ordering provider specialties. All of the specific guidelines for indications of urine cultures are present in the table on the poster. In regards to our results, 46.7% urine cultures had guideline-approved indications, with no statistical significant difference between guideline-approved indications with non-guideline approved or alternate reason or no documented reason for an indication. Out of all the inappropriately ordered positive urine cultures, about 59% patients received antibiotics. When we look at these results, we understand that there is no difference in whether ordered urine cultures have guideline-approved indications or not, and many of these urine cultures should not have been ordered as per our guidelines. Within the subset of positive urine cultures, there was no difference in whether the cultures were ordered with guideline-approved indications, and this leaves clinicians in difficult situations of deciding if UTI needs to be treated when faced with a positive urine culture. This is especially difficult in cases where no reason was documented by the ordering provider. In conclusion, future studies could investigate the use of urine culture order sets with guideline-approved indications on the order set and observe changes in these ordering strategies. We look forward to continuing on with this research and understanding more about different ordering patterns in our local community hospitals. We're happy to take any questions. Thank you so much for your time.
Hi, my name is Julie Blaine, and I am presenting to you today about our research from the OROC Clinic, identifying fracture risk, the benefits of OROC assessment at Niagara Health. This was done in collaboration with Dr. Ishkini and Brenda Lescombe, Dr. Halleck, and Dr. Robert McCloy. At Niagara Health, we remain committed to highlighting inclusion as a key driver for providing extraordinary caring, and just like to acknowledge the Indigenous Land Acknowledgement. This is the OROC Clinic. The purpose of this research was to do a quality assurance review to demonstrate the cost benefit of a multidisciplinary orthopedic radiation oncology clinic. Assessment for patients with metastatic bone disease of the appendicular skeleton at high risk of pathologic fracture. In terms of the literature, it has demonstrated that prophylactic fixation does reduce healthcare costs. Prophylactic fixation of impending pathologic fractures in suitable oncology patients does provide superior patient outcomes. There is a survival advantage for patients with femoral metastases who underwent prophylactic stabilization as compared to patients who underwent fixation due to an actual pathologic fracture. And postoperative radiation therapy does promote remineralization, provides pain relief, and reduces the risk of hardware failure. So the rationale of the OROC Clinic is to identify patients at risk of pathologic fractures of the appendicular skeleton. We provide education to patients and staff with respect to fracture risk and any weight-bearing restrictions. We provide rapid access to radiation therapy services at the Walker Family Cancer Center for patients with metastatic bone disease. And we provide timely access to surgical interventions which reduce pain, improve quality of life, preserve function, and minimize fracture risk. This is OROC. This was a retrospective case cost analysis completed looking at the dates of April 2020 to March 2021. We identified OROC patients who received prophylactic fixation or post-pathologic fracture fixation using Mosaic and Meditech. We compared length of hospital stay and any associated hospital costs. This data was sourced from the Niagara Health Finance Case Costing Department. And all photographs, tables, and graphs are the property of Julie Blaine. Our results have demonstrated 23 patients were identified from the OROC Clinic. 15 of these patients were identified as high risk and received prophylactic fixation. 7 patients had already sustained pathologic fractures. 1 patient did decline prophylactic fixation and then proceeded to fracture. On average, fracture patients stayed approximately 27 days longer in hospital. And on average, the fracture patients did incur costs greater than $17,000 more than a patient who underwent prophylactic fixation. This graph just demonstrates the 23 patients in total with the prophylactic fixation patients here with the number of 15 and the 7 patients that received fixation due to an actual fracture and the 1 patient who declined prophylactic and proceeded to fracture. The average age in years of the fracture group was 72.5 and the prophylactic group was 67.4. Surgical location was similar between the 2 groups with only 1 patient in each group that was required surgery to the upper extremity. This graph demonstrates the length of stay, which in the fracture group was 27 days average longer than the prophylactic group. Allied health costs were looked at, and the fracture group did incur approximately $800 more in allied health costs than the prophylactic group. Diagnostic imaging costs were much greater in the fracture group as compared to the prophylactic group. And this just demonstrates that the average cost per patient was approximately $17,000 more in the fracture group as compared to the prophylactic group. In conclusion, a multidisciplinary OROC fracture risk assessment can potentially result in substantial cost savings to Niagara Health for patients receiving prophylactic fixation due to a reduced hospital stay. Healthcare costs associated with impending and pathologic fractures is an important area for further research. References, and thank you for your time.
Hi everyone, Danny and I are pleased to present to you our project on optimizing the use of echocardiography in hemodynamically stable, normotensive patients with acute pulmonary embolism. This is a QI project conducted in community hospitals. Starting with some background information, pulmonary embolism, or PE for short, is a condition that is characterized by a blood clot in the pulmonary vessels, leading to obstruction and a multitude of symptoms. In more severe cases, PEs may lead to hypotension and features of right ventricular dysfunction, or RVD for short. Although most PE patients who receive anticoagulant treatment will have favorable outcomes, 10% of symptomatic PEs can be fatal within the first hour of onset, which is why we strongly believe that it's essential to recognize, diagnose, and treat PEs early in order to reduce morbidity and mortality. So currently, risk assessment of PE include clinical risk prediction scores that have been listed on our poster, in addition to factors including hypotension, assessment of RVD, and cardiac biomarkers, with the main indication being fluid unresponsive hypotension. In terms of diagnosis and prognosis prediction, CTPAs, or CT pulmonary angiograms, and perfusion scans are often preferred. However, transthoracic echocardiography, or TTE, may sometimes be used to confirm RVD. But this is where we've identified a problem. While RVD is common in patients with PE, it is really difficult to determine its clinical significance or severity in relation to cardiogenic shock without refractory hypotension. Furthermore, RVD is associated with low adverse outcomes. In other words, ordering TTE leads to no change in management in most cases. Despite these points, audits on the clinical indication of echo in acute PE patients have repeatedly highlighted inappropriate ordering practices that don't follow the 2011 American College of Cardiology Foundation's appropriate use criteria. This is problematic because TTE unnecessarily prolongs patient hospitalization and increases the burden on a hospital staff and resources. TTE is ultimately not warranted for patients who are normotensive with a low or intermediate risk PE. I would like to now quickly draw your attention to the fishbone analysis we have created. The identification of these potential causes that contribute to an increase in inappropriate TTE ordering practices has really helped us in brainstorming interventions to hopefully address the problem. Now onto our project aim. Our goal is to use multifaceted interventions to decrease the inappropriate use of TTE in stable normotensive inpatients with acute PE by 30% at the end of 3-month intervention period. At this point in time, I'd like to pass it on to my research partner, Danny, to walk through the remainder of our presentation.
So now we will be going through the methods and outcomes that we will be using for our project. With regards to our methods, our project timeline is divided into 3 phases. The first phase is our pre-intervention retrospective audit on TTE ordering appropriateness for admitted acute PE patients, where our goal is to identify the current practices surrounding TTE usage. Our second phase is our intervention stage. We have 3 interventions planned, the first of which will be to provide educational didactic sessions to inform healthcare providers on appropriate TTE indications for acute PE patients. Our second intervention will be to distribute a TTE ordering algorithm, shown in Figure 2, to help echocardiography technicians triage the appropriateness of TTE orders. Our third and final intervention will be to provide feedback reports to physicians who do order TTEs for their acute PE patients, in which we will indicate whether or not the order was appropriate. Following our interventions, we will have our third and final phase of our project, which will be our post-intervention retrospective audit. Our goal here will be to assess the effectiveness of our interventions. Now moving on to our study outcomes, the primary outcome that we will be examining is the proportion of inappropriate and appropriate TTE orders for acute PE patients during the pre- and post-intervention periods. In addition to calculating the absolute proportions, we will generate run charts and histograms to visually observe changes in TTE ordering practices over time using data from our audits. Our secondary outcomes will be to compare acute PE patients who did receive a TTE to patients who did not, with respect to rates of therapy change, rates of aggressive monitoring changes, rates of bleeding complications, and length of ICU or telemetry stays. The association between TTE ordering and these secondary outcome measures will be determined using independent sample t-tests and multiple linear regression models. In addition to our outcome measures, we will also have our process measures, which will include the rate of feedback letters sent per inappropriate TTE identified and rate of usage of our TTE ordering algorithm. Finally, we have our balancing measures, which will be to use a survey to gauge satisfaction among healthcare providers with our interventions. Currently, we are in the pre-intervention audit stage of our project, and we are hoping to begin implementing our interventions within the next few months. Our goal is that we can reduce the number of inappropriate TTE orders for acute PE patients to reduce the burden that is placed on patients, family, and healthcare resources. This brings our poster presentation to an end, so Ariel and I would like to thank you for listening, and if you have any questions, feel free to contact us.
Hello, everyone. I'm Miyazan. This is Ashish. We are both medical students, and we've been working on this project to reduce unnecessary red blood cell transfusions across the Niagara health system. I'll pass it over to Ashish to start us off.
So hi, everybody. I think the first thing I want to establish is that red blood cells are a scarce resource and that they cost about $2,000 Canadian to acquire and get delivered. And the second is that packed red blood cell transfusions can also cause health complications for the patients. So minor allergic reactions and transfusion-associated circulatory overload occur in about approximately 1 in every 100 transfusions, but serious complications also occur, and studies indicate that about 1 in 200,000 people will die as a result of complications from transfusions. So this all goes to say that transfusing blood is not something that should be taken lightly and should only be done when indicated, and that provincial and federal guidelines have been established based on studies which guide proper usage of packed red blood cells. These guidelines have been adopted by Choosing Wisely Canada with targets of 1, 80% of packed red blood cell transfusions occurring in patients with a hemoglobin less than 80, and 2, 65% of transfusions being for only a single unit. Now, the problem for us emerged when an audit was taken across Niagara Health sites, and what we found was that, yes, 85% of orders for blood met Choosing Wisely Canada guidelines for pre-transfusion hemoglobin less than 80, but only 55% of our orders met guidelines for ordering a single unit only. So as such, our objective or our aim was to reduce inappropriate usage of packed red blood cells across Niagara Health, and in doing so, meet the established Choosing Wisely Canada guidelines. Our approach to achieve this objective was to implement a multifaceted approach where we sought to improve appropriate PRBC utilization by about 15%. Now, the major interventions that we undertook as part of this could be categorized into educational strategies, the implementation of a PRBC order set, and transfusion medicine-led screening of orders for blood. Now, you can see figure 1 in our poster here, and it just kind of shows the timeline of the interventions. So in June of 2020, we updated the order set for ordering blood. In September, the transfusion medicine-led screening began. In 2021, between June and August, that's when we really focused on educational strategies. So that involved a bunch of posters and presentations. And in February 2022, we implemented a force function for a PRBC order set. Now, one other important thing to mention is that we aren't looking at every single patient. We are looking at patients under the care of the ICU, general internal medicine, and emergency department, specifically at St. Catharines, Greater Niagara General Hospital, and Welland Hospital. And we are also excluding patients in the OR, patients with cancer, or patients who are actively bleeding. So that is our approach, and I'll pass it over to Yazin to talk about how our approach went.
Perfect. Thank you, Ashish. So having established an area for improvement and the interventions that we wanted to use, we do have results. So over the last 1.5 years, since we first began implementation of MLT screening at these 3 sites, we have seen a general overall improvement in meeting both single unit transfusion guidelines and hemoglobin of less than 80 pre-transfusion. So while we see improvement at all 3 sites, our Greater Niagara General Hospital and our Welland Hospital have shown the greatest improvements. And in fact, they have been within Choosing Wisely guidelines for several months in a row and have been accredited as such. So the St. Catharines site, however, while it has met these guidelines for several months, it just has not met them consecutively. We suspect that there are several reasons for this. One, it is a larger site, so any intervention will take longer to bear to bear the outcomes that we're looking for. And two, that there are more massive transfusion protocols happening at the St. Catharines site since the patients that will require it end up there as opposed to at the smaller community sites. Conversely, we could also say that the MLT screening is more effective at smaller sites, and that will be important when we start looking at broadening the scope of where these interventions are used. So our overall recommendations are that we do continue to audit the data, especially since we only have 1 month since the implementation of force function. And from this 1 month alone, we can see a sharp uptick, but the future months should also be taken into account. And two, that the TM technologist-led screening is particularly effective in producing this improvement and meeting these guidelines. Of course, this is at an increased burden to MLT staff and does require funding. And so local and provincial efforts are needed to facilitate this. So thank you very much, and we'll be around for questions.
Use of specialized trauma carts in the emergency department, a scoping review. Dr. Oliver Shaw presenting on behalf of the research group. All hospitals have been gravely affected by the COVID-19 pandemic, and the emergency department is the entry point for all critically unwell patients. Emergency departments across the globe have therefore had to make unforeseeable changes to improve infection control in an era where all patients must be assumed infected. While COVID-19 transmission can occur at any time, aerosolized generating procedures significantly increase this risk. Solutions to combat infection risk have included social distancing in waiting rooms, staff personal protective equipment, negative pressure rooms for patients at highest risk, and the removal of equipment from rooms to prevent resource contamination. These changes have led to deleterious effects on hospital staff working conditions, as highlighted in the diagram. One significant challenge has been the storage of specialized equipment for high-risk interventions. While specialized emergency department carts have been shown to improve patient care, they also reduce staff footprint and resolve the problem of empty shelves once packed with hospital equipment. The objective of this study was to review the use of specialized trauma carts in the emergency department setting. A scoping review was completed using PRISMA extension for scoping review methodology to assess for evidence of current use of specialized trauma carts in the emergency department. An electronic literature search was conducted using appropriate search terms from 1995 to current date with no language restrictions. Titles, abstracts, and full articles were screened independently by 2 reviewers, and consensus was reached with the research team. Articles addressing the creation and implementation of specialized trauma carts, including burn injuries in the emergency department setting, were included. We extracted information addressing cart equipment composition, costs, implementation, staff evaluations, and patient care outcomes. This table presents the publications and findings of this scoping review. While none of the studies validated the specific use of trauma carts in the emergency department, they did show a strong positive correlation between use of standardized specialized carts and patient outcome. Specialties that have benefited include ventriculostomy supply carts, improving time for ventricular drain placement, burn management carts, and organization of trauma supplies, including equipment carts. There were several key findings during this scoping review. The specialized carts were able to deliver a shorter time delay between patient presentation and critical interventions, thereby improving provider efficiency and delivery of care. Having all equipment stored in a cart enhanced equipment access, reduced wastage, while improving infection control, a factor now more important than ever. Critical intervention equipment is usually stored within the cart drawers. However, for more rapid access, items can be located on top or attached to the sides of the cart. More efficient use of resources led to reduced equipment turnover and cost savings. As with all literature reviews, there are limitations to this scoping review. Due to limited research on specialized carts and lack of studies specific to trauma carts, more work is needed in this field. Most of the studies were conducted prior to the COVID-19 pandemic and therefore did not focus on aerosolized generated procedures and infection control. To summarize, all studies evaluated in the scoping review found improved overall patient care through the implementation of specialized equipment carts. This was as a direct result of enhanced equipment organization and storage. Carts led to decreased time to intervention and more efficient use of resources. No negative patient outcomes were observed. With the increased focus on hospital infection control in the post-pandemic era, in particular those pertaining to high-risk aerosolized procedures, trauma cart implementation in the emergency department will help prevent resource contamination and improve teamwork in high-stress environments.
Hello, everyone. My name is Quentin Carfadini. I'm a graduate student at Brock University, and I'm proud to present the study, What Factors Increase Odds of Long-Stay Delayed Discharge in Alternate Level of Care Patients. So first and foremost, I just want to give a quick shout out and thank you to Niagara Health for making this research possible, and to thank specific members such as Virginia Puller, Teresa Stroop, Deanna Comfort, and Dr. Brienne Hines for your commitment and support of this research project. So thank you. So beginning with a definition for alternate level of care, basically patients who are occupying a bed in which they no longer require that current level of care they're receiving, but continue to be delayed from discharge are designated as alternate level of care patients. A brief literature review around ALC patients. The importance of reducing these delayed discharges of ALC patients is paramount in aiding others in the hospital, including maintaining emergency department efficiency. So associations or factors associated with ALC designation in the literature include patients awaiting discharge to nursing homes, elderly population, the female sex, and those presenting with neurological disorders, especially dementia, as an example. So a quick clarification on ALC designation versus ALC severity. Majority of the studies in the current literature use ALC designation as their dependent variable. That is a patient that has accrued at least 1 day of one ALC patient day, as opposed to what we're going to use, which is ALC severity, in which we're going to dichotomize the ALC days to over or under 30 days, in which those over 30 days ALC are going to be classified as long stay ALC patients. Which brings us to the research question, which factors increase the odds of long stay delayed discharge in ALC patients? So our data was collected from the WTIS, or the Ontario Wait Time Information System, from September 2014 to 2019. The data analysis was performed using logistical regression, and our sample size included 16,436 patients, of which about 10% were considered long-stay ALC patients. The variables we included in their study were age, sex, admission source, inpatient service, discharge destination, and a plethora of needs and barriers requirements. So for our demographic and hospital location factors, initially what we see are a few things that pop out. First and foremost, males have a 22% more likely chance to be considered a long stay delayed discharge patient compared to their female counterparts. Additionally, when we look at admission source, those that come in from the ER are actually less likely to be long stay delayed discharge, and actually those who are directly admitted are more likely to be long stay delayed discharge patient. Moving to discharge destination, as we see, which has been corroborated in the literature, a fair amount, those awaiting LTC beds, such as nursing homes, those awaiting mental health beds and supervisor assisted living facilities are way more likely to be a long stay delayed discharge patient. For our needs and barriers results, we had a lot of different types of needs and barriers, but there were 4 main requirements that were significant both as a need and as a barrier. These would be bariatric requirements, behavioral, feeding, and infection isolation requirements. All 4 of these presented significant increases to the odds of becoming a long stay delayed discharge patient. In addition, just in terms of total barrier counts, each barrier present in a patient gave the patient 44% more likely chance to be considered a long-stay delayed discharge patient. In conclusion, long-stay ALC patients were more likely to be directly admitted males with discharge destinations to LTC and assisted living facilities. They were more likely to have the presence of at least one barrier. Among these barriers, the ones most likely to hinder discharge were bariatric, feeding, behavioral, and isolation requirements. If discharge destinations do not have the means or equipment to facilitate these transfer of patients, then their clinical conditions become slightly less relevant. And ensuring that these discharge destinations that are available can accommodate patients with these specific requirements that may help prevent delays once a patient has fully recovered from their acute illness. Thank you guys so much, and please enjoy the rest of the event. Thank you.